Assalamu alaikum, everyone, and thank you very much, madam. At the first place, since Sir is over here, he had worked with me at the University of Lahore for some time. My way of giving the lecture is a little bit different. It's usually the scenario based. Uh,
ठीक है
चलें। देखिए scenario based lectures, they have the different types of the impact, first of all, because we all concerned with the patient's management at the end of the day. Instead of going or digging very deep into the research ifs and the buts, I'll be as simple as possible, just trying to convey you the take home messages that how you are going to manage the simple case of the diabetes. So to recap everything which I have said earlier, is that is most of the teaching nowadays is based on the scenario based. Instead of going into or trying to dig very deep into the research, which most of us, even the teaching faculty who claim to be the researchers, and 99%, if I'm not trying to, if I won't dare to exaggerate, then 90 percentage of the faculty, they are not used to this type of the lectures. But this lecture is useful for the sake of four different types of the slides. ये मैंने रात को देखा क्योंकि I got free very late at night at 2, तो ये सोने से पहले मैंने देखा. So I have tried to incorporate one slide into it, because nowadays what we are seeing, there is a huge change in the trend as far as the management of the young diabetics are concerned. The youngest patient of type 2 diabetes, youngest patient so far in my career of 26 years, and especially working in the UK and then coming back to IMS from the UK back over here, this is the youngest patient of the diabetes that I have seen so far, of approximately 21 years of age. हाँ जी. अब majority आपको patients diabetics जो हैं, especially over the trend of last 30 years, and because the definition of the diabetes is almost the same that is used to be during our student life, that is in the late 90s and in the early 2000s. Definition is still the same. American definition is a little bit different. I don't know why. This could be a financially driven motive. Israeli definition is a little bit different. Well, Israeli says that according to the European criteria or according to the UK standards, all those patients, all those categories of the patient, that is a huge population of the patient, whom we declare as the impaired fasting glucose. That is a sugar in the range of 110 to 126. Israelis, they take them as the diabetes. Sure. Well, this could be a financially driven motive. This could be, I don't know. So I won't say a word, not more than that. Lekin, right now, over the last 30 years, a trend in the management of the diabetes gives you the take home message that diabetes should not be taken as a sole entity in the management ladder. This is the take home message, that's it, of today's talk. That's it, one sentence. That is, nowadays, majority of the patients, they would be obese. The BMI would be more than 28. They would be having a one form of the CKD or the other form of the CKD. आप अगर एक diabetic patient देखें तो hopefully we are going to give 4 or 5 different medicines. Antiplatelets, antihypertensives, antilipids, 2 or 3 medicines for the diabetes. So the 5 medicines will be put on the prescription. So another take home message is that is the diabetes management now usually takes into account, that is the associations. 3 types of the association they must be considered in the mind. One is obese patient, diabetic nephropathy, ischemic heart disease patient, and is the patient falling into the type of the special population. Now, अभी जो मैंने आपको example दी है, if I give you the data of it, how the things have become very much rampant in our population, that is among the Indians and as well as the Pakistanis. 21 years of age, Miss XYZ, unmarried, known case of epilepsy, under my care for ages, for more than 10 years, since I came back from the UK. Uh, she was maintained on the levetiracetam, seizure-free for more than 3 years. She came to me having the readings of fasting sugar of 295 and the random sugar of more than 450. HbA1c, which has been done 6 months back, that was giving us the HbA1c of more than 14. And now that is about a week back, that was she was having the HbA1c of more than 30. No family history of diabetes in more than two previous consecutive generations. Dada, Dadi, Ma, Ba, Ban, Mai. I really dig very deep into the family history because if the family history is there, she would be type 2. If the family history is not there, she would be type 1. The BMI, she was malnourished, जो कि होते हैं diabetic patients. BMI was less than 25. Waist hip ratio was less than 0.6. No thyroid associations. Cycles were good. No thyroid, no goiter, nothing. And I immediately requested a test in order to differentiate between the type 1 and the type 2. Distant relatives, they were the cases of the diabetes, but not the immediate family members or the next of kins. Anti-GAD antibodies. This is one test which we always recommend in this population. चुटाई वाले करते हैं 3 दिन में रिपोर्ट आ जाती है. आगा खान वाले करते हैं 6 दिन में रिपोर्ट आती है. If you don't want to wait for the 6 days, because the decision is going to be a huge thing, because once this very girl is going to be labeled as type 1 diabetic, and that stigma or the label is going to stick to her neck for the rest of her life. किसी ने जुर्रत ही नहीं करनी कि कोई देख ले कि टाइप 1 था कि टाइप 2 था.
टेस्ट का नाम बताओ.
GAT.
ये पेप्टाइड वगैरह से भी.
जी सर, अपना डीकार्बोक्सिलेज चुटाई वाले करते हैं. इतना महंगा टेस्ट नहीं है, 2300 रुपए का होता है. वेरी सिंपल. ये जो मैंने अभी और स्लाइड अपना इनकॉर्पोरेट कराई है वो इसी किस्म के पॉपुलेशन के बारे में है. आप बड़े ऐसे पेशेंट देखेंगे. आप अगर 10 मोटे डायबिटिक पेशेंट देख रहे हैं तो उनमें से 2 बच्चियां आपको या 2 लड़के आपके पास ऐसे जरूर आएंगे. 10 अगर आपने रोज के डायबिटिक पेशेंट्स देखे. So anti-GAD antibodies, they are going to differentiate is the patient a case of type 1 or the type 2. Type 1, this level would be sky high. In the type 2, this would be negative. So long gone are the days when we used to request for the insulin level and the C-peptide level. When we used to calculate the ratio, और वो रेशो कभी सही भी नहीं निकलती थी. फिर हम लोग then we used to scratch our head, is it type 1 or the type 2? और फैसल मसूद साहब से फिर अपना पूछा जाता था हमारे टीचर, and he used to give us a very ambiguous answer. अल्लाह का जन्म नसीब करे उन्हें. And lastly then at the end of the day, we used to put all these different types of the patient with the insulin. So missing the type 2 patient and giving him the insulin for the rest of the life, देखिए, try to put yourself, if we doctors are going to put ourselves in their shoes. क्या हम ऐसी बच्ची का रिश्ता लेंगे 4 टीके लाती है, शुगर के मरीज है, हफ्ते ही 2 बार शुगर लो हो जाती है. ऐसी है ना सर. And the psychiatric issues and the psychiatric problem is humongous. Just try to put yourself into your shoes. आजकल तो खैर अपना जमाना है, एपैथी का है. No one cares, no one seems to care, no one seems to notice. Everyone is just going to jerk off his shoulders and they are off. ऐसी है ना सर. So this category of the patient at the end of the talk, please try to keep all these patients in the mind. What you need to do, you're out of your very busy hours, क्योंकि family physicians तो बहुत busy होते हैं. अब हम लोग तो रात को तकरीबन 15-20 या रात को अगर 22 पेशेंट देख ले तो हमारी दिमाग की मेरा हाल दही भी नहीं बनती, बल्कि वो शोरा ही हो जाता है. तो हमारी तो बस हो जाती है. आप लोग के पास अगर ऐसा एक सिर्फ जस्ट स्पेंड अबाउट हाफ अ मिनट, कारी चोर किसी शुगर है, BMI you are going to visually analyze it. Simple as that. You don't need to do the formal measurements of the BMI, right, or the waist hip ratio. Just take the, just try to dig deep. Send the anti-GAD level. This is going to be differentiating points. Is it the type 1 or the type 2? NADA, MODI, I won't go into the details. So this slide is just trying to open us an idea that how much is the age adjusted comparative and the prevalence of diabetes. India, Pakistan, very high, very high. This has been said that every fourth or the fifth Pakistani is diabetic. And especially, यहाँ से आगे करें, यहाँ से
करके देखें यहाँ से कर लें
चले यहाँ से करें छोड़े अच्छा age adjusted again in Pakistan and India especially we always try to compare ourselves with the Indians so I don't believe in this data that is of the Indian 9.6% over here but Indians are more obese despite the Shakahari right सब्जियां तो दाना
vegetarian
आज vegetarian they are still more obese there has been a no mention of the Middle Eastern countries Abu Dhabi and Saudi Arabia Saudis lots of mandis shawarmas burgers and the pizzas right and total absolute lack of the exercise so we are not we shouldn't be trying to blame ourselves responsible for everything in the world the Saudis, they have not been mentioned over there. Third thing is, in this slide, multiple organs. Now, this is the, आप सिर्फ इसको जो है visually देखें. So, different treatment modalities, they are going to hit the gut, muscles, liver, adipose tissue, and the brain and the kidneys. So, secretagogues, they are going to act at the level of the pancreas, SGLT2 over here, metformin over here, liver, all the diabetic drugs, exception of the SGLT2, adipose tissues, sulfonylureas, and the metformin. Second message which this slide conveys is that these are the target organs that we have to consider ourselves at the end of the evaluation. Very rapid history, very rapid history. Very rapid historical evaluation. पैर ते नहीं सुन होंदे नेरे च नहीं डिग पैंदे कमरे नूं वेखो सब कुछ साफ आ रहा नजर कोई तारे ते नहीं नजर आए कोई अख ते कोई अपना पर्दा ते नहीं डिगा खास रुख ते वेखो दो नजर आते ने सिंपल क्वेश्चन वेरी सिंपल क्वेश्चन ये देखें हम लोगों ने चूंकि अपना यूके में काम किया हुआ है वेरी सिंपलेस्ट थिंग्स वेरी सिंपल जैसे इवन अ डायबिटिक नर्स कैन डू well, I don't have any hesitation in the acceptance of the fact that for the sake of the BLS, I was trained by an ambulance driver. मुझे तो कोई शर्म नहीं. In the BLS, I was trained by the ambulance driver, and the guy was extremely good. He was too good to be true. He was full of energy. Diabetic nurse knows a lot, hopefully better than me. Diabetic nurse. Whenever at the time of the difficulties, we always used to ask them. So, a very rapid question here. पेशाब किहो जिहा आंदा है और कदी पत्थरी बनी है सवेरे उठदी अखां थल्ले सोच पई हुंदी है और पेशाब चौखी झागा ला ते नहीं बनदा simple questions very simple questions as you are going to take the BP or you are going to just simply and write down the prescription on your letter pad you are taking the historical evaluation while at the same time. Very simple things. Yeah, this is it. ये मैंने छोटे से इनको कहा था कि algorithm छोटे बनाए. Now this is the first column is the cardiological risk assessment. You don't need to remember the whole of the tables. Don't need to remember. Now the things have gone by. To remember every book page by page is or word by word is not the requirement of the part 2 of any exam. It's not required nowadays. medcal एक है अपना कैलकुलेटर जी और उसमें सारा डाटा एंटर करते हुए आधा मिनट लगता है If the patient is having all the tests, you can easily categorize the patient into the high risk or the moderate risk or the mild risk. If the patient already having an evidence of the heart failure, just go through the medical record. Stroke and the TIAs, the patient is definitely going to give you the history. And if the patient is having any evidence of the CKD or the chronic kidney disease, if you just spend some 2 to 3 minutes on this slide, it's a very good slide. Cardiology is having the role of SGLT2 inhibitor, that is empagliflozin and the dapagliflozin. Now, if you look at the heart failure, again the SGLT2, stroke, pioglitazone, long gone drug, a dormant drug has again made to come back to life. Pioglitazone. Nowadays, even in my humblest submission, I say I only give Avendia, जो कि तकरीबन अपना मेरा ख्याल है उठा ली गई है पिछले तकरीबन 10 साल रीइंट्रोड्यूस की थी सर
with some reservation.
जी सर तो रोजिग्लिटाजोन जो है आजकल which is available by the name of the Solid and the Pio right, this is useful in the case.
Easily available.
हाँ जी तो Pio is we usually don't give, right? Because why? Because the Pio is going to increase the risk of the heart failure. This is going to increase the risk of the weight gain. In the weight gain patient, diabetic patient, weight gain is not required. This is the least thing that we need. Instead of what has been the use of the Zolid or the Piozor over the last 10 to 15 years? This has been in the management of the fatty liver disease. But we always try to hammer down this thing in his mind. कि हमने आपको जो दवाई दी है 2 मिनट हम लोग अपना काउंसलिंग करते हैं कि that you are going to be entered into a vicious circle. Pio, weight gain, aggravation of the fatty liver. Pio, the more Pio and the more weight gain and the more fatty liver. So, but it's a very good drug. It's a very good drug. Normalization of the LFTs usually occurs within a matter of 2 weeks. Then is the GLP-1. GLP is very expensive. हर कोई अफोर्ड नहीं कर सकता. They are available by the different names.
Affordable भी आ गई है.
सर आई डोंट नो, मुझे नहीं पता उसकी अफोर्डेबिलिटी के बारे में. मैं इनकी मिसाल यही देता हूँ कि जैसे इफ वी आर गोइंग टू गिव द रोसिफिन टू एनी पेशेंट एंड वर्सेस द सम अदर शालमी रोसिफिन, तो एंड द डिफरेंस इज ऑलरेडी देयर. सो चले आपको याद होगा जैसे अपना सोवाल्डी आई थी, इफ यू कुड पीपल रिमेंबर Sovaldi, which is still being used for the treatment of the hepatitis C. Now, Sovaldi at that time, back in the about 10 years back, 2015 and the 16, used to cost about 46,000. और उसके मुकाबले में
60 कुछ से शुरू हुई थी.
जी सर 60 से, लेकिन उसके मुकाबले में जो लोकल मेडिसिन थी 3,000, 4,000, 6,000. तो मैं कंपनी वालों को कहता था कि जी के चलो कितनी चोरी की होगी उन्होंने, 300%, 500%, okay, let's say. But look at the active ingredient. Out of hundreds of the patient of mine, only one patient remained negative after the use of the Sovaldi. One patient. और उनको मैंने कहा hold on. Hopefully after the end of the 2020, a new drug is going to come in. So I will test.
ये जो सोवाल्डी थी अमेरिका में जब इंट्रोड्यूस हुई है, one tablet की कॉस्ट $1,000 थी. $1,000. उसके बाद ये कम
हो गया
90,000 बनता था डॉलर.
So I don't know about the quality or the efficacy. I usually give that is Ozempic. And moreover now the patient psyche is like अगर आप कोई सस्ती दवाई लेके दे देना पेशेंट कहना है कि देख के देता है.
Depends upon the pocket of the patient.
It depends on the pocket of the patient, especially the category of the patient which they visit us.
And their willingness.
And willingness. अच्छा अब ठीक है जी. Sorry. Okay. वही. मैंने नहीं कुछ किया. अच्छा okay.
हो जाएगा. अब वेट कर ले.
So the pocket of the patient, status symbol, right? Status symbol आजकल हम लोगों को खा ही गया है ये अपना मोबाइल फोन की वजह से. स्पेशली जी नहीं जी ओज़ेम्पिक तो सारी दुनिया लगाती है, आप हमें कुछ और बताएं. लगा चाहिए अपना मुंजारो ले लें. अच्छा मुंजारो जी कहाँ से मिलेगा? मैंने कहा इंग्लैंड से मिलेगा या दुबई से मिलेगा, जब मंगवा दो. ओके शेयर विद अस. So status symbol competition is,
यहाँ
this
पे
is the third
जो
epidemic.
गा रहे थे कोई 1 लाख 1.5 लाख 2 लाख तो
जी सर, ऐसे ही है।
नेट पे मैंने सर्च किया तो अवेलेबल हो गई है, लेकिन कोई लाखों
लाखों में सर। अच्छा, CKD patients, we are very much concerned about the GLP and the SGLT2 inhibitors. Now, this is a few words on this last part of this slide. These type of the patient for the sake of the identification of your eyes, any patient who is going to be obese, hypertensive, poorly controlled, sugar control, creatinine of 1.4 would be in this category. फिर सुने diabetic, मोटा, hypertensive patient, right? Creatinine of 1.4, which we always take it for granted because if the creatinine is going to be risen from 1 to 2, the GFR has already fallen by 50%. 50%. So creatinine of 1.3, diabetic, obese patient, hyperlipidemic, might have had NMI back in the past, about 6 years back. This is this category of the patient which we really need to hit. A few words about the targets. The targets, they must be individualized. Any diabetic patient, let's say poorly अंदरूने शहर अपना ग्वाल मंडी, राइट, और द DHA गाय, राइट, or obese patient, diabetic for more than 20 years, who has been playing with this medicine for ages, कदी वो दवाई कदी वो दवाई, just for the sake of the status symbol. या जो अपना ग्वाल मंडी के लोग हैं हमारे, जो खाते ही नहीं, जिनका खाना ही नहीं खत्म होता, ठीक है जी, तो गुजराला है. So in these poorly controlled status of these two different types of the extremes, one side of the grass and the other side of the grass, targets should be individualized. If you are going to aim for the target of the fasting sugar of less than 110, they are going to experience the symptoms of the hypoglycemia. So 150, 180, random would be 180 to 220. And the HbA1c target, instead of less than 6.5, it must be 7.5 to 7. Right? And the patient must be consulted for the GLP. अब ये देखिए, ये जो अमेरिकन्स ने किया हुआ है, DPP4 is not mentioned in the first column, right? देख रहे हैं आपको DPP4 नजर नहीं आ रही. Old-fashioned drug, which I consider very useful, Metformin, is not mentioned.
ये एंड नीचे आ गए आधा वो ऊपर हो जाए
जी. Metformin, sulfonylureas are not mentioned. These are the new guidelines, and वाकई our experience says that the Americans are right. एक सेक्रेटरी साहब आते हैं वहाँ से इस्लामाबाद से मुझे अपना दिखाने के लिए, creatinine of 1.8 got improved to 1.4, weighing of 130 kg, right? Eating, obsessional eating, or HbA1c 8.6. So about 2 weeks back, now I have given him the Victoza, right? And the Trulicity. अब उन्होंने फोन पे बताया my sugar has dramatically improved within a matter of 2 injections. Sorry. So, and the sugar has just only giving the 2 injections of the Trulicity, the patient sugar control has dramatically. Right? So the take-home message is, we are not going to say that in this category obese patient we only need to give the empagliflozin or the Mounjaro or the Ozempic or the Trulicity. You can have the combinations. You can incorporate the Metformin if creatinine is less than 1.4 in males and 1.3 in females. So if we look at the last slide now, if still Metformin is in the middle, right, the biochemistry, the biochemical picture has to be taken into account. If still the sugar level, or if the HbA1c of less than 7 at the end of the 3 months is not being achieved, then we can make use of the other drugs, the You can have the combination of the first two drugs, that is the GLP-1 RA or the SGLT2. So there is no mention of the sulfonylureas, right? Order of medicine, yeah. Order of medicine. So to cut the long story short, so order of medicine, first choice of the insulin, NPH or the regular medicine or the regular insulin. This all these things, choice of insulin, choice of the drugs, choice of the DPP4 or the choice of the SGLT2, this must take into account associations, obese, CKD, TIA, stroke, cardiological risk, very high. You can, so इसको consider करें. This is the whole thing that we need to consider, nothing else. Yeah, one of, especially in our setting where the affordability of the patient really is a matter. So what do I do is, if the patient is obese and the patient is having any of these risk factors, I incorporate the SGLT2 with the metformin and with the diamicron MR, because if you are going to give the Gatril in this category of the patient, the weight gain. So make use of the diamicron. 120 milligram of the diamicron is safe. जी
वेट गेन तो उससे भी होगा
वेट न्यूट्रल
सिंगल डोज
जी सिंगल डोज भी दे सकते हैं, तोड़ के भी दे सकते हैं जो आप सिंगल डोज भी देखिए सर, जो आपके पास तीसरे दिन चौथे दिन when the patient is going to have a follow up on the third day with you people and having the sugar record, so you can make a choice, either you want to give the BD dose or you can have the 120 milligram once again depending on क्या शुगर का आया बैटरी. So this is again overweight, obesity, right? If the sugar control is not being controlled with the GLP-1, you can have the add-on of the thiazolidinedione and the sulfonylureas, they say, as I have already mentioned clearly. Sulfonylureas, they must be avoided. देखिए, diamicron MR is the weight neutral. Sulfonylurea is the weight gain. Sulfonylurea is going to give you the benefit of the dosage marker. आप 8 मिलीग्राम तक तो दे सकते हैं ना, of the Gatril, Amril and the Glimepiride.
8 मिलीग्राम
Diamicron सिर्फ 2 गोलियां.
ये उसका डिसएडवांटेज
ये उसके डिस्काउंट. तो बेहतर है कि जो if you have reached the maximum dose of the metformin, if we have reached the maximum dose of the DPP4, and if we have reached the maximum dose of the SGLT2, instead of playing with the medicine, one should have a strong counseling. Either you need to have the basal insulin, दिन में एक बार insulin, or you need to have basal insulin, or if the patient is not willing to use of the is not willing to use the insulin, then of course the GLPs they can, but the GLPs are very expensive.
अगेन वो इंजेक्शन
अब लेकिन हफ्ते में एक बार ओरल आ गई है, लेकिन हफ्ते में एक बार कितने इंसुलिन सर रोज रोज लानी है. ये भी तो एक एडवांटेज है ना, देख आप अपना वंस वीकली इंसुलिन करा. Lastly is that is a metformin again. Please, this is a third take-home message, 60 to 45. That is creatinine of 1.1 to 1.3 in case of the females, and 1 to 1.4 in case of the males. If you have the calculation of the GFR, this is usually in the range of 60 to 45. So you can continue with the metformin, but you got to monitor the GFR after every 3 months. If the GFR is less than 45, caution is there, because if you are going to give the metformin, high incidence of the lactic acidosis and the high incidence of the diarrhea. Diarrhea बड़ा common है ये metformin के साथ. Next one is less than 30. If the GFR, so round about this gives you the creatinine of 1.8.
सर इसमें जो आपने 45, 30 में तो उसमें मेटफॉर्मिन मैक्सिमम कितनी देर से?
जी, यानी कि देखें ना, the maximum dose of the metformin is in the patients who are not having any evidence of the CKD is 2.2 gram.
Yes.
So if the GFR is 30 to 45, 1 gram should be the
1 gram. 1 ग्राम दे सकते हैं।
1 ग्राम दे सकते हैं, बट GFR must be monitored after every 3 months. RFT is rule. Lactic acidosis in the patients of the CKD is not going to be acceptable. A very complex slide I'm going to omit. It's just the repetition of the same things approximately. Acha, a few words especially on this thing. In patients of ESRD or stage 4 CKD, GFR of less than 20, this SGLT2 should be avoided. This can be a reason for the glycemic ketoacidosis.
उसमें एम्पा और डेपा की सेम है इंडिकेशन या कोई फर्क?
नहीं सर, ना दें तो बेहतर,
ना
ना दें बेहतर है, because these patients are going to have
20 से नीचे है
20 stage, even in the presence of the cardiological disorders. अवॉइड कर दें, बेहतर है. UTI, vaginal infections, fungal infections, pyelonephritis. So at the end of the day, where there is going to be the sugar, high incidence of infection, जिधर चीनी उधर infection, उसको अवॉइड करते हैं. Another thing is that is SGLT2 inhibitors. One thing is, so any patient who has been on the AMPA or the DAPA must have the urine complete after every 1 month. If the leukocyte esterase is there, nitrite is there, go for the urine culture and give the antibiotics and stop SGLT. जी मैडम, यूरिन कंप्लीट 600 रुपए में 400 रुपए में हो जाता है, छोटी लैब 300 में भी कर देती है, क्योंकि
इसको टेम्परेरी स्टॉप करें या बंद कर?
सर वो कहते हैं कि if there has been more than 2 episodes of the UTI in the previous 6 months, avoid.
लेकिन हमने नोट किया है यहाँ पे हमारा एक्सपीरियंस ये है कि इतना यूटीआई कॉमन नहीं है हमारे यहाँ, ड्यू टू कि हम वॉश करते हैं, वो लोग टॉयलेट पेपर यूज करते हैं.
हाँ जी है, आप बिल्कुल ठीक कह रहे हैं सर, लेकिन जब डायबिटिक पेशेंट
है वो सिर्फ वो टॉयलेट पेपर यूज करते हैं, देयर आर चांसेस ऑफ और चांसेस ऑफ यूटीआई.
जी सर,
आपने अभी एंड स्टेज वाला कहा कि whosoever is taking
is on the any patient who has been on the SGLT2 more than 2 episodes of the UTI in the previous 6 months, avoid, better to avoid.
यूरिन का जो आपने कहा है कि
हाँ जी, हर पेशेंट में करे सर जो कि SGLT2 पे है. मैं आपको बताऊं, शायद आपने मेरा ख्याल है नहीं ना इतने पेशेंट देखे हो या क्या. आज हमने SGLT2 यूज किया एक बूढ़ी अम्मा को, तीसरे दिन अम्मा आ गई सिस्टाइटिस के साथ.
बहुत कम ऐसे
नहीं सर
के बाद ये ज्यादा कि मैं भी
नहीं मैडम, एज जो है इसके बारे में उन्होंने कहा है नहीं. हाँ जी, ओल्डर एज में भी इंसिडेंस हो सकता है ज्यादा, लेकिन जैसे all those patients who are going to have the rapid excretion of the AMPA into the urine, or the half-life of the AMPA in the urine, or the tubules is high, there is going to be the very high incidence of the UTI. बूढ़ा बंदा 80 साल तक पहुंचता उसका GFR पहले ही 70% पे गिर गया, तो आप एक यूरिन कंप्लीट करा दिया करें हर पेशेंट, सिर्फ यूरिन को, आम सा टेस्ट,
ठीक,
बड़ी सिंपल सा टेस्ट है. और लैब जी
4-5 रीडिंग्स में नेगेटिव आ गए हैं,
तो सेफ है, फिर तो सेफ है.
हम इस गैप को बढ़ा सकते हैं.
हाँ जी बिल्कुल, आप बढ़ा सकते हैं.
मंथली की बजाय
हाँ जी आप दे सकते हैं बिल्कुल, क्योंकि देखिए इफ यू एनकाउंटर अ UTI in the diabetic patient, believe me, management of these patients is a nightmare, क्योंकि any type of the organism is going to be there, and colonization of the genitourinary tract will be there. आप कल्चर कराएंगे फिर आएगा, फिर कल्चर कराएंगे फिर आएगा.
10 और 25 एम्पा में, उसमें 25 में ज्यादा चांसेस होंगे.
जी सर 25 में ज्यादा है, मैंने कभी आज तक नहीं दी कभी 25
10 तक.
हाँ जी, क्योंकि इतने ज्यादा मेरे पास UTI के पेशेंट्स आते हैं तो मैं डर गया हूँ, ऑनेस्टली स्पीकिंग. हाँ जी मैं 10 तक रखता हूँ.
डेपा भी 5 तक देते हैं.
डेपा सर मैं अपना 10 तक दे देता हूँ. मैं आपको एक और अपना बताऊँ, ये ICU CCU में रोज का मामूल है, रोज का मामूल. मैं मतलब कि just giving you an idea about the SGLT2 inhibitors in the second population of the heart failure. उमर हॉस्पिटल में आए दिन हम लोग ऐसे पेशेंट देखते हैं, हफ्ते में 3 बार 4 बार। इजेक्शन फ्रैक्शन ऑफ 20%। क्लासिक ज़्यादा दे नहीं सकते। अल्ट्रा फिल्ट्रेशन करते हुए हम लोग डरते हैं क्योंकि डायलिसिस की देने के ऑप्शन। तो मैं हमेशा नेफ्रोलॉजिस्ट को कहता हूँ डिक्रीज लो डाउन द डोज ऑफ द लासिक्स and increase the amount of the AMPA. So when you are going to increase the amount of the AMPA, free water and the patient going to have the polyuria and the patient will be diuresed. ये भी करवा रहे थे देसी जुगाड़। So metformin mode of action, UKPDS, very huge study, very old. 86, 87, if I remember correctly, this was done. There is a huge benefit of the metformin. There is no second question about it. मैं इसलिए नहीं कह रहा मैं यूके ट्रेंड हूँ या अमेरिकन नहीं अच्छे लगते, बाकी जो सही बात है सही। This has been the comparison. One of my brothers, he had been maintained on the metformin monotherapy for more than 10 years. So metformin is still everything. So this is the incidence of that is immediate release metformin and the metformin XR. So this slide is going to give you the take home message. Let's say if you are giving 1.5 gram metformin to anyone, और अम्मा आती है जी डायरिया लग गया या पेट में दर्द है या नोजिया वोमिटिंग, so don't lose your heart. Don't immediately try to swap or switch from the metformin to the sulfonylureas. Instead reduce the dose and give the XR preparation. Glucophage XR is easily available in the market, 500, 750 and 1 gram. So इस पे भी कुछ पेशेंट अपना सेटल हो जाते हैं. Why we are so much consistent with the metformin is that this is a time tested medicine. जी
50 साल तो हो गया,
50 साल हो गया, लो कॉस्ट है, बेनिफिट्स आर आउट ऑफ द प्रोपोर्शन।
अमेरिकन ने बहुत बाद में इसको
एक्सेप्ट किया, लेकिन मेटफॉर्मिन स्पेशली ओबीस, देखें the uses of the metformin now they have extended beyond the diabetes. PCOS, polycystic ovarian, we always give the obese non-diabetic patient for the reduction of the metabolic syndrome, impaired fasting, impaired HbA1c, मोटा, glucophage.
PCOS में आप बायोपीटर जो भी तरफ
वेट गेन करती है सर, इसलिए नहीं करते हैं। देखिए ना, मतलब कि छोटी सी बात है, 2 लफ्ज़ी, इंसुलिन रेजिस्टेंट स्टेट associated with the obesity, metformin must be given. Hypothyroidism, polycystic ovarian, obese diabetic, having the sign and symptoms of the insulin of the resistance, गर्दन काली, ये काला, कंथुसिस निग्रिकन्स, ये हमेशा metformin होती। Third thing is monotherapy, yes, dual therapy, again the same thing over here, right? Metformin, right? Metformin, मुश्किल हो गया, क्यों जी? ऐसे ही है ना? Creatinine in case of the females of 1.3, in case of the males this is more than 1.4. So metformin मुश्किल हो गया था इधर जहाँ पे, right? So this is again all the pharmacology. These are the EMPA-REG trial, yeah, this which was done. If I remember correctly, this was done in the European countries. I don't remember how we think. Like, these are the benefits of the EMPA. So, hypertensive benefits, weight loss benefits, arterial stiffness, atherosclerosis, cardiology, all those things. Difficult, too many research, kidney disease, weight loss, yes. Meta-analysis, BP reduction, same things, insulin.
इनका वेट लॉस कितना है एज कंपेयर टू मेटफॉर्मिन?
ये सब मैं आपको दिखाता हूँ, ये देखें, ये इधर sorry, I just missed it.
Weight loss
ये ना Meta-analysis of the 43 RCTs compared the SGLT2 with no drug has reported that a mean reduction of 1.88 kg. So, so what has been the mechanism? Again, the same. That is the loss of the sugar into the tubules. Right? I haven't come across any study जिसमें उन्होंने insulin resistant state में the monotherapy in the form of the metformin and the monotherapy in the form of the AMPA compared किया. So I don't know if we have the comparison of the metformin and the AMPA, how much would be the reduction in the weight. But hopefully, if you have the combination of the AMPA and the metformin, reduction in the weight will be ज़्यादा. So this is BP reduction, we know that, right? Insulin independence, low risk of the hypoglycemia. Then is this one. This is my favorite. I have treated 2 patients of the euglycemic DKA at the University of Lahore ICU before moving on to the into the public sector. I worked over there. So my career has been a little bit swap up and down. Came back from the UK. Joined New Hospital as the senior registrar. और आपको पता है जिस किस्म का हमारा कल्चर है द poking in the nose, right? So I was not promoted to APA. मैंने कहा okay, then I'm going. And then I came to the University of Lahore where I served for more than 14 years. और फिर उसके बाद यार दोस्तों ने कहा आजा वापस. Then last year I appeared in the public service exam for the same post of the professor of medicine. Then I was selected. So this is difficult to diagnose, right? This thing is difficult to diagnose. No one thinks of it at the first place. Euglycemic DKA, because this is contrary to the usual definition of the DKA. The patient will not be hyperglycemic. The ketone urea would be there. Sugar would be generally less than 180. But these patients, they do occur. And you need to have a very low threshold. Treatment is almost the same. So, if you see any patient who is dehydrated, abdominal pain, and if the patient is having the sugar level of less than 150, but he is throwing lots of the ketones into the urine, always think of EDKA, euglycemic DKA. So if you are going to encounter this patient, please do not give SGLT2 in the same patient again. Okay? So metformin and the AMPA, lots of benefits: cardiology, nephrology, metabolics, right? Triple therapy, DPP4. Yes, we like it. And हम लोग देते भी हैं. So especially obese patient में, our typical prescription is that we give the Dapamet. मैं अपनी prescription आपके साथ ही share कर देता हूँ. Especially obese, diabetic patient, RFT is good, LFT is good, mota. Or then you need to give the Dapamet 10 by 1000 and Sitamet XR 100 by 1000. 3 things are being given. Metformin maximum dose of the 2 gram and the 10. I don't usually give the 25 milligram of the DAPA. Instead of instead of increasing the dose of the DAPA, I usually prefer either the basal insulin or the weekly GLPs. 25 से मुझे बड़ा डर लगता है. Really, honestly. Emphysematous pyelonephritis, we have treated 3-7 patients, right? UTIs, almost of the daily occurrence, right? इसलिए मैं बड़ा डरता हूँ कहते. So GLPs, they can be given. History is there. They were devised from a fish. और in the service commission के भी एग्जाम में उन्होंने मुझसे ये पूछा था. And to my surprise, and that question was not being asked by one of our teachers. That question was asked by General Aziz himself. तो मैं मुंह देखने लग पड़ा, मैं क्या so diminished average. So this is again the GLP is metabolized by the DPP4. So a new DPP has been launched by sorry, in the presence of one pharmaceutical company, I can't name the other one. Once weekly DPP4 has been launched today. Tidzi. Tidzi. Tidzi, sir. Tidzi. Tirzee. Tirzapite.
Tirzapatide.
Ajaj. Tirzapatide.
That's one.
That's one of them. तो मैं क्या मैं उनकी चुटकी में नहीं लेता हूँ. अच्छा, the same thing. The linagliptin has made our life very easy, right? Instead of giving the sitagliptin, we try to prefer the linagliptin in the special population. Special population जो पिछले दिनों especially मेरा experience रहा है, that is the renal transplant patient who has been on the peritoneal dialysis, and the patient who has been on the hemodialysis patient.
जीना की मिनिमम क्या
5 milligram is the maximum.
नहीं उसको EGFR कितने ये
This is safe in renal.
सेफ
Whatever the GFR you can give.
ये दे सकते
G. Maximum dose is 5 milligram. So in this special kind of the population, trying to achieve the HbA1c of the less than 7 is really hell of the job. Difficult patients for the sake of the sugar control that I have encountered so far, that there has been a liver transplantation patient. Because the basal insulin or the long-acting insulin, they have been said to be not recommended by the Americans. Short-acting insulin or the medium-acting insulin must be given, but high.
बेजल भी नहीं हो
बेदल भी नहीं सर वो recommend करते. बड़ा सिर्फ अभी तक 2 ही पेशेंट अपना लिवर ट्रांसप्लांटेशन किसी ने सर अपना रेफर किया था. अल्लाह ने इज्जत रखी, उनकी शुगर कंट्रोल में गई. So does the combination therapy improve the compliance? Yes, the number of the drugs, number of the tablets, but another point which has been risen by the patient recently, quite recently, about a month back, कि डॉक्टर साहब एडी वड्डी गोली है किस तरह निकला.
ये अक्सर पेशेंट
अच्छा कहते हैं, तो मैंने कहा जी तोड़ के खा लिया और बाकी दिए. फिर उन्होंने कहा जी थोड़ी बड़ी है. मैं कहता हूँ तो जवाब नहीं, फिर चीनी भाग लिया करो ना.
तोड़ने से उसका मैकेनिज्म तो नहीं डिस्टर्ब होगा.
नहीं सर, अभी तक कंपनी वालों ने नहीं कहा. नहीं सर, कोई नहीं कहा अभी तक. इन्होंने यही कहा है कि ये एंटारिक कोटेड अगर टूट भी जाए तो कोई नहीं, लेकिन जब तोड़ेंगे the active ingredients are going to come out and they would be so bitter.
अच्छा
तो मैं कह रहा हूँ खा लिया करो अखा बंद करके. बड़ी बड़ी गोली है. So this was the last slide of the lecture. My favorite slide. This is I highly recommend this slide. In the part 2 of the endocrinology, we always ask this question. So Miss X ABC, 21 years of age, clinical assessment, which I have already mentioned earlier. GADA, that is anti-GAD antibodies, they have been run. So our patient was over here. She was over here. This was, I was not having, I was not having the results of the GAD antibodies still with me. Okay, so what they say? They say glycosuria pre-diagnosis, CRP less than 5 or sensitive to sulfonylureas. Now that girl, she had already been given Keter, reasonable dose. They say this LADA patient, LADA, latent autoimmune diabetes, this patient usually responds to the sulfonylureas of 2 milligram. 3 milligram.
Living right.
Huh? Because this girl, she had been given before me 8 milligram of the glimepiride and she was having the sugar of sky. I did the LFTs and I made sure that she was not falling into this category, right? So I stopped this and straightforwardly said, Beta, instead of going into any ifs and buts, leave it, what the heck? You have been given the maximum dose of the recommended medicine and no sugar control has been achieved. Let's have the insulin.
Insulin.
Simple as that.
क्या
Insulin?
Insulin.
हाँ वो ऑब्वियस
No insulin. Instead of kadiyo.
सेल
One should not, why to play with the medicines or swapping around? Simple as that. So this type of the testing, since it's not available with us, right? Even this type of the testing is usually available जहाँ पे circulated काम कर रहे हैं आमिर चीमा जहाँ वो especially because the Detroit is the center of the cardiology and the endocrinology. This type of the testing is not available, universally available, even in the UK. So, well, the Americans might have been, मैंने कभी अमेरिका काम नहीं किया मुझे नहीं पता मैं तो UK पे हूँ. The Americans might have been doing these types of the testing almost on the daily basis, but we usually don't do. So this we usually stop over here. And this patient is going to give us clear-cut idea what to do next. So if a young diabetic patient who is deaf, so this is type 1 or 3 moody. If this patient is mildly fasting hyperglycemic, sugar is HbA1c is in the range of 6.5 to 7.5. She is not obese, LFTs are good, fatty liver disease is not there, cycles are good. So this can be managed with diet control. Third category, yep, not having this, slow dose of the sulfonylurea. If not controlled, shift to insulin. And this thing, renal says genitourinary abnormalities like what? Duplex pelvis, duplex ureter, right? LFTs are there, and the dyslipidemia, insulin. तो ये टेस्टिंग कराने की to my very humble submission is just simply the show off.
जेनेटिक टेस्टिंग हो रही है कि ना
सर इस यहाँ तक हमें बड़ा आइडिया मिल गया कौन सा अंडरलाइंग अपना डिफेक्ट है माइटोकॉन्ड्रियल है किसी की है मतलब जब 1A है या 1B है we are having a very reasonable amount of the idea by the clinical scenario.
कैड एंटीबॉडीज का आपने जिक्र
जी easily available.
Nobody has yet mentioned बहुत लेक्चर्स कराए हमने इधर भी
चलो कोई बात
नहीं सुना
कोई बात नहीं 2200-2300 रुपए का टेस्ट होता है आपको ऐसे पेशेंट्स मिलेंगे मैं आपको पहले बता दूं महीने में एक पेशेंट 2 पेशेंट आपके पास आएगा सो दिस इज सो यू वुड बी गाइडेड बाय होलिस्टिक पिक्चर बिल्कुल आराम से 3 मिनट सोच के यू कैन मेक अ वेरी स्ट्रेट अवे डिसीजन Any questions?
टेस्ट हो रहा है मतलब इंसुलिन भी तो डायरेक्ट कर सकते हैं
सर नहीं होता नहीं मिलता
सर मैंने आज एक
C
पेशेंट
peptide
देखा
insulin.
था यंग पेशेंट अबाउट 25-30 उसको खाली ये एक था मैंने उसकी शुगर चेक की वो ठीक थी
हाँ जी
उसमें और क्या उसके करना था
हाँ जी अपना लिपिड्स करें LFTs करें और BMI निकालें and the patient definitely would be a case of the metabolic syndrome X. Trying to spend about half a minute as far as the family history is concerned, especially sudden cardiac death. Sudden cardiac death is defined as death within 4 hours of the cardiac event, clutch. And the premature CAD or the coronary artery disease, males less than 50, females less than 50 grams. So I would definitely want to give him the metformin. Low dose, 250 BD. And the patient
even
is,
if he is not diabetic
even if he is not diabetic, because the cardiological or the benefits of the metformin, 250 BD, and the patient needs to be counseled a lot. क्या थोड़ा रखा? Anything else?
Thank you. Any other questions?
बहुत बड़ा क्लियर कर दिया क्वेश्चन का
Thank you very much, sir.